I know it was a lengthy and difficult stuff uh, because majority of you don't have any experience of ICU or especially with dealing with the non-invasive ventilation that is ventilator machine. But at least you should know the basic settings of the ventilator machines. Now we have two chairperson arrived for this scientific session. I will request Dr. Jamaluddin, Professor of Medicine from KTH, to please come to the stage and have your seat. And I will request Professor of Medicine from Sedu Medical College, Dr. Abdul Ahad, to please come forward to the stage and have your seats. अच्छा, आप सब जितने भी पैनल ऑफ एक्सपर्ट्स हैं, स्पीकर्स हैं, आप सब लोगों ने अपनी अटेंडेंस और ये मार्क कर लिया है? कोई रहता तो नहीं है? उशू अटेंडेंस. Okay, now coming towards the next presentation for our next speaker, management of shock in ICU. That is very important, and what every internist should know about it. I will request this Associate Professor of Medicine, Dr. Mohammad Haroon, to please come forward to the stage.
Bismillahirrahmanirrahim. I am Dr. Mohammad Haroon, working as Assistant Professor, Department of Medicine, Khyber Teaching Hospital. I also I am also supervising the Medical Intensive Care Unit of Khyber Teaching Hospital as well. So today we have selected very good topic for presentation, that is shock in ICU. Shock is basically a common problem in intensive care unit, requiring immediate diagnosis and treatment. As we know that the shock has got very high mortality in our setup, and worldwide it is about 20 to 50%. So timely diagnosis and early intervention may save lives. It can be defined by a combination of hemodynamic parameters like MAP, which is a mean arterial pressure less than 60 millimeter of mercury, and systolic blood pressure of less than 90 millimeter. There is clinical finding like altered mentation, decreased urinary output, and there would be abnormal laboratory values like elevated lactate level and metabolic acidosis. So we all know that how we can calculate the MAP. MAP is basically when we divide the pulse pressure divided by 3 plus diastolic pressure, we can get this MAP, mean arterial pressure, and it should be more than 60 to 65 to perfuse the vital organ. Second is the systolic blood pressure. It should be more than 90 millimeter of mercury. And the urine output we should know about is 0.5 to 1 ml per kg per hour. So you should early monitor the urinary output in these situations. As we know that there is problem when there is tissue hypoxia because of shock, there is anaerobic respiration at cellular level, and the lactate level would become high, and there is metabolic acidosis as a consequences. Now coming to the pathophysiology of shock. Shock occur when the rate of arterial blood flow is inadequate to meet the tissue metabolic needs. This results in the regional hypoxia, subsequent lactic acidosis, and anaerobic respiration, which causes end organ damage and failure. Now it is just a very simple classification of shock. Hypovolemic shock. As we all know that when the intravascular compartment is depleted because of hypovolemia, either traumatic hemorrhage, exsanguination, hemothorax, hemoperitoneum, or fracture, multiple fracture as a traumatic consequence. Or there may be non-traumatic hemorrhages like GI bleed. As we know, we are working in medical units, so in every emergency we get patient with variceal bleed. There may be other causes of blood loss like abdominal aortic aneurysm when it ruptures, or ectopic pregnancy rupture, which is a topic of obstetrical gynecologists. Other causes of hypovolemic shock is burns in which the fluid is lost from the skin. And when there is skin integrity loss, like toxic epidermonecrolysis, a dermatology topic, if there is persistent vomiting, diarrhea, dehydration, or we get patient with diabetic ketoacidosis, hyperosmolar coma, in which there is fluid loss because of dehydration. There may be other diseases which we get in emergency department is acute pancreatitis, huh? And there is third space collection like pleural effusion, huh? Pancreatic fluid collection, huh? And we get decreased intake because of anorexia or some chronic illnesses. So the patient may present with hypovolemia and dehydration. Other second type of shock is cardiogenic shock. When the cardiac pumping is impaired because of some diseases of the myocardium, or if there is any valvular lesion, like in myocardial diseases, we get myocardial infarction, dilated cardiomyopathy, then mechanical causes are aortic regurgitation, papillary muscle rupture because of ischemia as a complication of MI, and acute valvular rupture from abscesses as a complication of infectoendocarditis. Ventricular aneurysm rupture, and then as we know, ventricular septal rupture, these are maybe a complication of ischemic heart disease and acute myocardial infarction. Ventricular free wall rupture, these may occur. So all these may end up with the cardiogenic shock. Then there is rhythm problem. If severe bradycardia or tachyarrhythmias, ventricular fibrillation, all may end up with cardiogenic shock. Third type of shock is obstructive. Obstructive shock is when there is obstruction to the filling of the cardiac chambers, like in pericardial tamponade, tension pneumothorax, or constrictive pericarditis, or if a very large embolus stuck in the pulmonary trunk, massive pulmonary embolism, that may cause obstructive shock. Severe pulmonary hypertension it has been written in the literature that it may cause obstructive shock if the pulmonary hypertension goes up. As a complication of, we get patients with acute severe asthma, COPD patients, and as a ventilator, when there is severe obstruction and poor ventilatory settings, the patient end up with a R2 PEEP from mechanical ventilation. And R2 PEEP, what causes R2 PEEP is it causes obstruction to the inflow of blood toward the heart, and it is a cause of obstructive shock as well. Then the fourth one shock is the septic shock. Distributive shock or vasodilator shock, and septic shock is one of the example of distributive shock. What occur in distributive shock is there is widespread vasodilatation, so that when there is vasodilatation, the preload or the blood coming to the heart will be impaired. What occur in the septic shock is there are microbiological agents like bacterial endotoxin causes nitric oxide release due to ischemia from the vessel wall, which causes widespread vasodilatation, and again the result is a distributive shock. Then coming the anaphylactic shock, the immunoglobulin E, and it causes anaphylaxis, causes vasodilatations, interleukins and vasodilatation. Third one is the neurogenic shock. Then we have adrenal insufficiency. Now, we usually work in the emergency department, medical department. So the clinical present, how the shock patient will present to you. So neurologically, these patients develop with altered mental status because of poor cerebral perfusion. These become anxious, disoriented, delirious, and there may be frank obdentation, or even they may become unconscious and the GCS will become low. So these are neurological manifestation of shock. Then the cardiovascular symptom, the patient may present with chest pain. The blood pressure, when you check it, is the systolic blood pressure would be less than 90 millimeter, and MAP again it will be less than 60 to 65. There may be other signs as attributed to specific shock, like if the patient has got cardiogenic shock, there may be cool peripheries. When you touch the patient will be cool and sweaty, and the capillary repel time will be low. There may be weak pulses, and chest examination would show coarse crepitations. JVP may be up, will be raised, and there would be hepatojugular reflex would be present. There may be S3, S4 gallop on clinical examination. Then if the cause is septic shock, no, it causes vasodilatation, so the periphery would be warm to touch, and there would be bounding pulses. You may get the electrocardiographic changes on the ECG because of a shock. These may be ischemic change like ST depression, T-wave inversions. There may be enzymatic evidence of myocardial damage like raised troponins. And if you do the echocardiography, there may be signs of poor ejection fraction and myocardial ischemic changes, like you can get the one motion abnormality, any valvular rigor you can pick on the echocardiography. Then the respiratory manifestation of shock is there would be increase the respiratory rate, the minute ventilation would be increased, and consequently the respiratory muscle fatigue may occur because of as on one side we have poor perfusion of the muscle, and secondly the oxygen consumption would be increased in these situations, so the patient may go into the respiratory failure. Then renal wise, due to renal poor perfusion of kidneys, the urinary output would be decreased. There would be renal ischemia and acute tubular damage may occur, and the patient may go into uremic encephalopathy. Then gastrointestinal manifestation, as we have seen a number of patients having raised transaminases because of ischemic injury to the liver. There may be stress ulcerations, peptic ulceration, and bacterial translocation of bacteria. So secondary septic shock may occur in these shock patients. Hematological complication of the disseminated intravascular coagulation, you can have low platelets, prolonged PTA, PTT, and D-dimer would be raised in disseminated intravascular coagulation. And again, the musculoskeletal complication may be there, may be weakness and increased fatigue. So now, how you will monitor shock in your setup, especially in ICU and in emergency department? We have standard monitors, like we can attach the monitor with the patient, and we have regular ECG monitoring, like we can pick bradycardia, tachycardia on this. So regular ECG monitoring is important. Then the pulse oximetry, so we can check the saturation of oxygen from finger pulp. So the saturation should be more than 94% as an M to improve perfusion of the tissues. Then we can have a BP cuff and we can monitor the non-invasive blood pressure in our setup. We can have temperature probes, huh? So we can have temperature record of these patients as well, huh? And then again, urinary catheter should be potent, so early urinary output should be monitored in these patients. Now we have monitors of tissue perfusion, that how our resuscitation effort have improved the peripheral perfusion, and how we can monitor these arterial line. We can put an arterial line in the radial artery, femoral artery, and brachial artery. So one advantage of this arterial line is we can have invasive blood pressure monitoring from that. Beat to beat, you can get the blood pressure measurement. Secondly, we have to take frequent blood sampling from these, and arterial line have the advantage that we can have a regular sampling of the blood samples whenever it is required. Then we have central venous line placement, central venous catheter placement, like we can put in the subclavian vein, internal jugular vein, and femoral vein. So you can have the in the central vein, subclavian, you can have central venous pressure monitoring can be done through this CVC line. Then echocardiograph, bedside echo should be available in ICU and in emergency setup. So you can have the valve motion abnormalities and ejection fraction. You can be measured from the bedside tools like echocardiography. Then we have metabolic indices, that if we take blood, we start resuscitation of a septic patient or any patient with shock. The initial blood the sample may show metabolic acidosis and hyperlactatemia, raised lactate level. So consequently, we start the resuscitation efforts, so we can monitor that whether your pH is improving, your lactate level is improving. So these are the metabolic indices which should be monitored in the ICU setup. When coming to the investigation, we have CBC. CBC is basic investigation, and have a lot of information is there on doing this CBC. It may cause low HB if the patient is in hemorrhagic shock, so you have this hemoglobin and hematocrit, low platelet, maybe because of some disseminated intravascular coagulation, raised TLC or very low TLC may be indicative of septic shock. Again, the electrolytes, again, there you can get the hyperkalemia because of if renal perfusion is impaired because of shock. There may be deranged renal functions, and the patient may go into may have these hyperkalemic changes that may be evident on ECG as well. Then the glucose, the glucose range should be in 140 to 180 milligram per deciliter for good outcome. Moreover, we can have risk factor. Sorry.
We are short of time.
Okay. Okay. So these are the investigation, ECG, chest X-ray. Then now I come to the management of shock. We have general management and specific management. In general management, we should monitor for the airway. If there is any secretions, we should clear this, put in oral airway or nasopharyngeal airway. And if the patient is not breathing, you can put in advanced airway for invasive ventilation. Then breathing, again, circulation. Then we have specific management of shock. In hypovolemic shock, you will replete the intravascular compartment with IV fluids, ringer lactate or normal saline. In hemorrhagic shock, you will replete with the red cell concentrate, and tranexamic acid 1 gram state, and then 1 gram over 8 hours in CRASH 2 trial that was conducted on trauma patient. Monitoring, we should monitor the CVP. It should be more than 8 But if your patient is not maintaining MAP, you can add this NARAD as well. Uh, so treatment of the cause for any hemorrhagic shock. Then cardiogenic shock, again we will start with the inotropic support. Initially NARAD and then dopamine can be added for good perfusion of the tissues. And then in shock trial 2021, that was on coronary artery disease. If it is the cardiogenic shock is secondary to acute myocardial infarction, straight away go for percutaneous angioplasty and coronary bypass to improve the outcome. Then obstructive shock, we should address the cause and treat according, like tension pneumothorax. You can have tube thoracostomy, and abdominal compartment syndrome. You can go for laparotomy. Pulmonary embolism, you can have this thrombolytic therapy and embolectomy. Then distributive shock, septic shock, you start with the IV fluids, challenge 20 to 30 ml per kg, and start with NARAD support and address any precipitating cause for that, and should address the infective focus that should be removed as early as possible. Thank you.